My name is Balade Shipelu. I'm a medical student at the University of Toronto. So I'm going to be introducing a very exciting lineup of speakers for this talk entitled Eating Disorders in Muslim Youth, Who Am I Fighting For? Before we get into it, just some housekeeping. So for the Q&A period, speakers are more than happy to answer your questions. Just make sure you put them in the Q&A as opposed to the chat. Feedback for the session and conference will be provided digitally after the conference with a Google Forms survey. And because all these sessions are accredited today, including the research poster session, to receive these hours, please complete that survey that you'll receive in your inbox. And as we said earlier, resources are available at www.muslimmentalhealth.ca and continue to engage with this conference via social media using hashtag CMMHC2022. So what I'll do is I'll introduce the speakers sequentially. We're going to be starting off with Dr. Sarah Smith. So Dr. Smith is a clinician investigator and a consulting psychiatrist in the eating disorder program at the Hospital for Sick Kids. And then once Dr. Smith is done, I'll introduce our next speaker. Please take it away, Dr. Smith.
So when you say take it away, do you want me to say more about myself or to launch into my slides?
Whatever pleases you. You can feel free to talk a bit more about yourself, and then you can get into the presentation.
Okay, sure. So introduced, my name is Sarah Smith. I'm a child psychiatrist. I work right now at Sick Kids, and my area of focus is eating disorders. I've been asked to speak tonight for about 20 minutes as a kind of introduction to the topic of eating disorders. And so I will do that before moving on to other speakers in this group. And I assume if someone can't see this, you'll let me know.
We're able to see it.
Perfect. So eating disorders have received a fair bit of attention lately in the media. You may have heard that more and more children and youth are presenting for care, or that we have long wait lists for that care. Those things are true, but there's also a lot of misperceptions around who eating disorders affect or what these illnesses actually consist of that I'm hoping to speak to tonight. Kind of to that end, we were given 5 objectives for this talk. I'm going to speak about risk factors for eating disorders, an overview of common medical and psychiatric impacts, red flags, as well as resources for frontline providers. And I'll provide a little bit of information about kind of principles or levels of treatment. The expertise and cultural competence around this area does not lie with me. So what are eating disorders? Eating disorders are really serious mental illnesses that are characterized by either eating too much or too little, often accompanied by other serious or dangerous behaviors like making oneself vomit, exercising excessively, or taking medications not prescribed by a physician to manage weight. These illnesses are associated with very high rates of medical complications affecting almost all systems of the body. Some of the most severe ones affect people's digestive systems, their heart, and the levels of minerals or salts in their blood. I'll come back to this topic a bit later. We also know eating disorders tend to be associated with other medical or psychiatric diagnoses. For instance, things like depression, anxiety, or diabetes. And the presence of these illnesses can make eating disorders harder to treat. Eating disorders on their own, though, affect almost every domain of young people's lives. For example, they have real impact on relationships with families, with peers, with other important adults, as well as effects on academic performance or ability to do other developmentally appropriate things, like take on family responsibility, begin looking to work or roles outside of the home. And unfortunately, actually have some of the highest mortality rates of any psychiatric diagnoses. Over time, between 4 to 8% of affected youth may go on to die of these illnesses. And that's quite concerning because we know from kind of large representative studies in Australia and the United States, countries similar to Canada, that somewhere between 7 and 13% of children and adolescents endorse concerning eating disorder symptoms. Unfortunately, we don't have good representative data from Canada, but I think it's safe to assume that we probably have similar rates of prevalence here. Eating disorders are also like super complex illnesses, and we don't know exactly what causes them. There have been many theories, and these theories have changed over time. But kind of at a minimum, we typically agree that there tend to be biological contributors, social contributors, and then psychological contributors. For example, we know that young people who have family histories of anxiety, depression, eating disorders tend to be at higher risk. That would be a biological risk factor. We also know that young people who are more anxious, more harm avoidant, tend to be at higher risk. So I'd call that kind of a psychological risk factor. And then we know that many circumstances that might lead someone to change their eating can be a trigger. And so that can be things we commonly think of, like dieting with the intent of changing the way one's body looks. But we also see clinically that changing eating for other reasons, things like wanting to be healthier, perhaps having been unwell and then being afraid of consequences of eating, like vomiting, can actually lead people into this cycle of disordered eating. So I think eating disorder requires some combination of a young person who is vulnerable through their biology, their psychology, and then something, typically an event or influence, kind of triggers this cycle of changes in behavior around food that becomes very difficult to intervene with or control. I think it's also important to clearly say that eating disorders are not choices. They are devastating illnesses that no patient I've ever met would kind of choose to have if they had the ability to control their illnesses. Nor are they things that are families' faults, although families can be very helpful with kind of seeking care and ongoing care. The fact that we usually encourage the involvement of family in treatment does not mean that we think that families have caused their eating disorders. There are kind of many well-established risk factors for eating disorders. As I mentioned before, people who have family histories of mental health concerns or disordered eating tend to be at higher risk, as are those who have certain personality traits, kind of not listed here, also things like being rigid, perfectionistic. We also know that young people who are in environments that give them very strong messages about the importance of body shape or weight in terms of success, health, desirability, are at higher risk, as are young people who identify with a gender that does not match their assigned sex, or those who have sexual orientations other than heterosexuality. Medically, we know that young people who have other health concerns that tend to focus on food or weight as part of their management, things like diabetes or inflammatory bowel diseases, are at higher risk. We also know that some activities that are very focused on weight or appearance can be triggers. Examples that come to mind are things like participating in dance or perhaps endurance sports like running, where it is valued to have kind of as fast or lean as body as possible. And then kind of the final big risk factor is dieting, although the word kind of restricted or limited eating for any reason probably fits there. But I want to make clear that having a risk factor means somebody is at higher risk. It doesn't mean that they're guaranteed to develop eating disorder, nor does it mean that someone who doesn't have that risk factor isn't at risk. We are seeing an increasing number of young people in services who don't have many of these risk factors, or who have characteristics that we used to consider atypical. Things like being male, like being quite young, think younger than 12 years old, kind of before puberty, or have historically lived in a larger body. And those young people, through some combination of these kind of biological, psychological, social factors, are still ending up engaged in disordered enough, even that they require hospitalization. And so clinically, I would encourage you to think that everybody is at risk of an eating disorder, and to always have some awareness of that in interactions with young people in any mental or physical health setting. There are kind of many established warning signs for eating disorders. Most notably, parents, teachers, perhaps healthcare providers tend to notice really marked changes in how young people eat. That could be skipping meals, that could be removing entire kind of components of someone's diet, be it meat, dairy, perhaps gluten, with the intent either of losing weight or just being healthier. Because of this focus around changed nutrition, we tend to see young people want to eat alone, kind of away from their families, away from their friends, or we see them just pass on social situations that involve food. We also tend to see them talking a fair bit about kind of weight, food, health, or engaging in kind of frequent checking behaviors. The example here is a mirror, but young people might also be weighing themselves. They might be measuring parts of their body. And then doing that with other abnormal behaviors, things like vomiting after meals, exercising all the time, taking supplements or medications not prescribed by a doctor to lose weight, always disappearing after meals, which tends to be to vomit, or showing behaviors that are the opposite of kind of very limited eating. So actually eating large amounts of food, binge eating, which can be foods considered unhealthy in many settings, in a way that makes individuals feel out of control. They also tend to be quite embarrassed or ashamed about either their excessive or their binge eating, or their very restricted eating, and quite reluctant to talk about these things, which are all hallmarks of their illness. And so I would encourage anyone who sees these patterns of behavior in a young person to be concerned enough to tell that person that they are worried, and to encourage them to engage in help seeking. Probably initially to see their primary care provider, which could be someone like a family doctor, pediatrician, a nurse practitioner, to actually have an assessment of what is going on in the moment, if it is a diagnosis, if there is kind of acute medical risk, as well as recommendations for treatment. And I say this because, as I mentioned before, eating disorders affect almost every system of the body. The most kind of concerning changes you tend to hear about happen with salt or mineral balances, the heart, the digestive system, hormones, bones, kind of teeth, dentition, and your blood. So anytime someone is not eating enough, or doing things to get rid of food, such as vomit, purposely in a way that leaves their body deprived of nutrients, function, including muscle function, changes, which is important because your stomach, of course, is largely made of muscle, as is your heart. So young people who are engaged in very restricted eating tend to have discomfort when they eat. Their body gets like deconditioned, I would say, to normal eating, which can present as stomach pain, as as difficulties using the bathroom, as well as changes in enzymes, like from your pancreas and your digestive system. In terms of your heart as a muscle, we will see heart rates go way down to dangerous levels, where they actually risk sometimes stopping. We'll also see abnormal rhythms. Hormonally, we'll see young people kind of stop laying down bone, stop growing appropriately, and then not meet milestones like puberty. We will also see kind of decreases or changes in almost all bloodlines, as well as what can be quite marked changes to teeth from vomiting. And I say that because dentists are not an uncommon place for eating disorders to be detected. Disordered eating kind of also really affects brains. The pictures I have chosen here show that brains that are not getting enough nutrition actually shrink. And that causes people to struggle to think in ways that are clear, to focus on things other than food, and to be like rigid or sticky. They can also appear quite anxious and obsessive around things other than food, as well as have really drastic fluctuations in mood. And so mood can go up and down, accompanied by anger, by behavioral outbursts that are typical for somebody, or just remain kind of quite low. Sadness or depression are very common eating disorders because the actual amino acids that we need to build the chemicals for our brain to work right are found in food. The combination of these things can make a young person seem like a different person. And I highlight that because I want to make it clear that that is illness. It's not willfulness or bad behavior. Those are all signs someone is becoming more and more unwell as their eating changes. We also know from other studies that the way brains function in terms of electricity, blood flow, are quite different for people who have eating disorders when presented with kind of stimuli of food. And so things like pictures, exposure to scents, actually are processed differently. People will perceive those things as sources of fear, or they won't have any kind of pleasure associated with them, the way that people who are not eating disorder would. That tells us that eating disorders are biological kind of brain-based illnesses. People are literally wired differently. And because of that, these illnesses often require professional treatment. In Ontario, and actually across Canada, we treat child and adolescent eating disorders in 4 different levels of care. The most common is outpatient treatment, which is often publicly funded through hospitals or community mental health agencies. It typically consists of medical monitoring, that is, having a physician or a nurse practitioner monitor weight, vital signs, as well as for all those scary complications I mentioned before, as well as psychotherapy. And psychotherapy is actually the mainstay of treatment. There are multiple kind of models or types we talk about. These include family-based treatment, cognitive behavioral therapy, and dialectical behavior therapy. And what all these things have in common is they focus on change in behavior, on normalizing eating, as well as sometimes teaching other skills to cope with stress or distress. we don't spend a lot of time anymore focused on kind of why something happened or taking it away. Only through addressing thoughts, because we increasingly know that doesn't work. And our intent is always to get somebody well as quickly as we can, because we know we have a critical window of about 3 years when someone develops an eating disorder as a child or an adolescent, during which their chance of recovering and going on to live a fulsome, kind of typical, healthy life is the highest. For patients who are not able to benefit from outpatient care, kind of the next level up is day hospitals. Day hospitals typically involve going to a program, often located actually in a hospital, during kind of office hours, so Monday to Friday, usually 9 to 4-ish. And these programs are focused on psychotherapy, but they also involve supervision of meals and snacks, as well as usually a way to attend school and earn some academic credit. The third level up is residential treatment, which is usually considered appropriate for people who need kind of supervision, support with meals, outside of just kind of weekdays during the day. So they need 24/7 care. In Ontario, we provide residential care at one center, the Ontario Centre Shore for Mental Health, and I can't speak to the details of where or how it's provided outside of Ontario. The last level of care, kind of inpatient care, is what most of us think of when we hear of hospitalization. So I'm talking about kind of typical medical hospitals. Inpatient care for eating disorders focuses on acutely making someone stable enough or safe enough to transition to outpatient care, because we know that actually outpatient care has the best outcomes for most young people. So those inpatient hospital stays tend to be brief. They tend to be focused on getting enough nutrition in to have someone's kind of heart or other body systems be safe, or to manage acute psychiatric concerns like thoughts of suicide. We also kind of think about risk whenever someone is hospitalized. Of course, being in hospital takes a young person away from their family, away from school, or away from other things that make their lives meaningful. I should also probably mention before I leave this slide that there's kind of very little evidence for the use of medications in treating eating disorders. Sometimes things like anti-anxiety or antidepressant medications are used to manage kind of co-occurring conditions, but they don't always work well when patients are quite medically unwell. And research shows kind of real risks to their use, or not always a lot of benefit. And so whether or not someone may get medication would be a recommendation made by an individual provider, but I just kind of want to make it clear here that typically the mainstays of treatment are not medication for these illnesses. Kind of lastly, if there are people here who want to learn more, who want to share recommendations with kind of families they serve, friends they know, I think the best book out there on eating disorders is How to Help Your Teenager Beat Eating Disorder by James Locke and Daniel LaGrange. It's commonly available, and it provides kind of education on many of the points I've talked about tonight, but in more depth. And it also provides some helpful hints around seeking or navigating care. Within Ontario, Dr. Ahmed Bawachi and Karen Jesper have published another book that really talks about identifying patterns of behavior and when to be concerned. And then online, the most kind of common organization I hear of is called Feast. It runs online forums as well as education sessions for parents around eating disorders, tending to focus on children and youth. For older patients, there is a group in Ontario called Body Brave, which provides education as well as support groups, although to my understanding, they serve those older than 16 years old. That. Which brings me to the end of kind of my spiel. I will be happy to take questions. I believe after other panelists have spoken.
Yeah, thank you so much, Dr. Smith. Next up, we're gonna welcome Dr. Nazila Isgandarova. She has a PhD from the University of Toronto, a Doctor of Ministry degree in Pastoral Counseling, Marriage and Family Studies from Wilfrid Laurier University, and a Master of Social Work from the University of Windsor. She is a Master of Pastoral Studies Director and an assistant professor at Emmanuel College of Victoria University and the University of Toronto, teaching mental health, psychopathology, and psychotherapy courses. Her book, titled Muslim Women, Domestic Violence and Psychotherapy, Theological and Clinical Issues, was published by Routledge in 2018 and Islamic Spiritual Care by Pandora Press in 2019. Please, let's welcome Dr. Isgandarova to the stage.
Okay, thank you so much. It's a great honor to be here with you. Unfortunately, so virtual. Hopefully next year we will be in person. Thank you for invitation, for your hard work. And we all know that this is a very sensitive topic for all of us, including other mental health issues as well. I would like to share my screen. Let me share my screen first. Okay, so I would like to start with important statement. First of all, I would like to mention that when we look at the association between religiosity and mental health problems, literature teaches us that usually there's a negative association between high religiosity or deep religiosity and psychiatric symptoms. However, when it comes to eating disorders, unfortunately, we see high association between deep religiosity and eating disorders, specifically anorexia nervosa and bulimia. Thank you, Dr. Sarah, for explaining the symptoms, highlighting the risk factors, and also association and also impact of cultural and social rules in respect to eating disorders. I would like to mention that when we look at the eating disorders among Muslim patients and the high risk of hospitalizations among the fasting Muslim teenagers, some Muslim teenagers, and eating disorders, of course, we don't want to give a message saying that there is high association between fasting during Ramadan and other times and eating disorders. Our purpose here to highlight the importance of identifying risk factors and prevent eating disorders among Muslim patients, specifically around the month of Ramadan and other times as well. I would like to mention that this problem does not only exist in Islamic tradition or among Muslims. Multiple research also shows that in other religious traditions, they also discuss the high association between religiosity and eating disorders as well. I would like to highlight the report analysis of psychiatrists who in 1988 analyzed 250 patients, including Catholics and Jewish patients, and reported that there's a higher rate of self-reported religious identification than the general population when it comes to eating disorders. However, there are some studies, including Latzer, who in 2007 reported that greater religiosity was not always associated with lower rates of eating disorder symptoms among the school-age girls in Israel. However, some studies also show that in countries where fasting is not common, and there is a less kind of association to spiritual tradition, religious traditions, the rate of anorexia nervosa and bulimia nervosa is significantly low. And they give an example from Finland. Finland is largely a Protestant country, and many research studies shows that there's a rare incidence of fasting and eating disorders in Finland in comparison to other European countries. Research also talks about polyanorexia in different religious traditions, including Islamic traditions as well. Some research studies also highlighted spiritual starvation as well. I would like to give a historical kind of narrative in order to understand where it comes from and how we should understand eating disorders in our current context. The early description and the description of eating disorders goes back to 300 AD, where they talked about the religious people, highly religious people, who wanted to fast in order to deepen their spirituality and religiosity and beautify the spiritual side. In 12th and 13th centuries in Europe, there were miracle maidens, and these miracle maidens, they used to fast for spiritual and religious purposes. I would like to give an example of famous spiritual personality in Roman Catholicism. For example, Catherine of Siena, she usually fasted and to a point of self-starvation. And then she was also known to have engaged in frequent bouts of self-induced vomiting. And from today's perspective, we can say that she seemed to have probably bulimia nervosa. But in 16th century Roman Catholic Church recognized the danger of this kind of fasting, and they prohibited this kind of fasting in the 16th century. The first cases of disorder, like in today's understanding, goes back to 17th century when Dr. Richard Morton, he diagnosed this disease as a wasting disease of nervous etiology in one male and one female. And then we know that Sir William Gall, physician to Queen Victoria, she named this disease as anorexia hysterica, but later on, he removed the title from the anorexia hysterica. He removed hysterica and simply called it anorexia nervosa, which literally means a lack of appetite. So now let's come back to anorexia nervosa in Muslim context. Unfortunately, we don't have many studies. Hopefully in near future, we will see a significant number of research studies to look at eating disorders from Muslim perspective. But I would like to highlight few studies in United Arab Emirates and also from Turkey, because they really inform our understanding how we should treat Muslims who suffer from eating disorder with cultural sensitivity. Previous studies amongst the United Arab Emirates citizens shows that there is a relatively higher rate of eating disorders among Muslims in this country, specifically amongst the females. So, for example, Thomas and et al. In 2018 reported that more females in United Arab Emirates suffer from anorexia nervosa than males. And this, he then gave an example or analysis to understand that why more females in United Arab Emirates suffer from anorexia than males, and also bulimia than males. And he gave an example of social factors, cultural factors, and also religious factors as well. For example, one study shows that ideal female body and ideal female type in these countries are those who are thin and also religious. So definitely there is not only religious factor here, but also social factor, how the society see ideal female body. In another study, it is suggested that when we study eating disorders among Muslim patients, definitely we need to consider culturally reactive syndrome. And also eating disorders among Muslim females specifically should be accepted as a dysfunctional response to sociocultural change as well. And there is also one study that highlights high relationship between perfectionism and eating disorders, specifically obsessive compulsive disorder and eating disorders as well. One study in Turkey, especially about Akgül, I really highly recommend to study her report. She also highlights ethnic and cultural differences among Muslims in respect to body image and ideal body weight. And she also invites us to consider risk factors of these eating disorders, which include individual self-perception on ideal body weight, the influence of family members, peers, and media, and other socio-demographic characteristics as well. Some studies also invite us to pay attention to clues about the importance of certain cultural triggers. For example, in Turkey, we know that when fasting comes, approximately 60% of the population plan to fast. And in other Muslim countries, for example, in United Arab Emirates, Pakistan, Indonesia, Saudi Arabia, Kuwait, we expect a little bit more people to fast when during the Ramadan time. So we all know that Ramadan is a holy month for us, and all Muslims expect to pay attention to spiritual aspect of this month. Ramadan is not only the month that we fast and we refrain from eating, but we also pay attention to refrain from other things during Ramadan time. For example, to refrain from backbiting, and we also pay attention how we can purify our spiritual aspect during the month of Ramadan. Unfortunately, Ramadan is also a month where many Muslim patients who suffer from eating disorders start having some kind of battle in their mind how to manage Ramadan and the triggers during this month. Ramadan is the 9th month of Islamic lunar calendar, and we all know that the timing of the month usually changes each year. It usually starts from dawn and lasting until sunset, and the days usually change from 29 days to 30 days. And the duration of the fasting also changes depending on the season. So we expect the shorter hours during the winter time and also longer hours during the summertime. But longer hours of fasting can be extremely challenging for those who are not healthy. And we can include people who suffer from eating disorders among the people who, according to Islamic jurisprudence, can be considered not healthy. Ramadan has certain religious practices, rituals, and but these rituals require that only healthy and adults should fast and do Taraweeh and other spiritual practices. According to one research on eating disorders and the Ramadan, they talk about how we should address stigma when it comes to Ramadan. Because in some countries, we know that if you don't fast, there can be some punishment or even penalty. And these countries can include Saudi Arabia, Kuwait, United Arab Emirates. We can include a number of Muslim countries. So this is one of the trigger points for many Muslim patients who suffer from eating disorders and other health problems too. So I think that little advocacy is required in this respect, how we should manage this problem. According to Islamic jurisprudence, a healthy fasting is when the person who keeps a fast and eats 2 meals, one before dawn and one after sunset, known as sahur and iftar. And we know that fasting also changes the use daily habits. And of course, we don't say that all people who fast develop eating disorders, but we know that some people are prone to develop eating disorders during the months of Ramadan. And we need to pay attention to risk factors because these risk factors play an important role. Why some adults and adolescent populations, they develop eating disorders during and also after Ramadan. Eating only within a short overnight span leads to several behavioral changes that includes sleep rituals, eating schedule, and mealtime habits as well. One study in Turkey reports that there is an increase of patients with unhealthy and disordered eating patterns who sought treatment in Turkey's most prominent hospital, which is called Hacettepe University, and many adolescent adults get treatment after Ramadan, even during Ramadan, as a division of adolescent medicine shortly after Ramadan time. So definitely this shows that the trigger was associated with Ramadan fasting. Of course, fasting is a sacred duty during Ramadan, but how we can help people who suffer from eating disorder to fast in a healthy way and not suffer from the triggers of eating disorder. So that is a question. And here comes the role of addressing stigma during Ramadan time. Some countries can be a good example, positive example for this. For example, we know that in Turkey, restaurants and cafes are usually open even during Ramadan time. So, and another stigma is associated with the fact that in some countries, in some communities, if you don't fast during Ramadan time, and even if you are not healthy, there can be stigma attached to that. Some people might see you not as pious, and definitely that indicates stigma attached to not fasting during Ramadan time. So this needs to be addressed in the Muslim communities as well. For us, Quran and Hadith are two important sources that we derive and we rely on in terms of our spirituality and deepen our religious understanding. Quran in this aspect is specifically very, very important, and Quran is very powerful tool to address this stigma and also help people who suffer from eating disorders. First of all, some patients who suffer from this eating disorders report that Ramadan can be triggering because they know that during Ramadan time, no one is going to blame them for not eating because everyone is fasting, and if they don't eat, no one notices that they don't eat. However, when we break the fast, then it is noticed that people who suffer from eating disorder, they don't eat, or shortly after they eat, after they break their fast, they can purge. So this is kind of issues that we also need to address amongst the patients who suffer from disorders. So again, coming back to the powerful tool in our Islamic tradition, the Quran. Quran encourages us to keep our body healthy. Because when our body is healthy, our emotional state is healthy, emotional healthy state is healthy, and also our spiritual health is also healthy. So Quran tells us in the Surah chapter 7, verse number 157, God allows for them as lawful tayyibat in all good things, these beliefs, foods, person, and prohibits for them as unlawful khaba'is, all evil and unlawful thing. These beliefs, persons, and food. And Quran also tells in the Quran that don't expose yourselves to ruin. For example, if we know that when we don't eat, it is going to harm us, then Quran highly discourages not eating in an unhealthy way. Quran also says that my Lord has forbidden all atrocities, whether overt or disguised, and harm, ism. And when we look at the harm of eating disorders, then we can say that eating disorders, anorexia nervosa and the bulimia nervosa needs to be addressed from this aspect because it damages and causes harm to our body and emotional health. And here comes a role not only of patients, but also families and communities' responsibility, how they should be active in preventing risk factors. Okay, let's look at the second important source in our tradition, which is the Hadith tradition. We know that Hadith comes in many ways. Although there are criticisms against some Hadith literatures, we can still use the Hadith literature to empower people who suffer from eating disorders. I would like to give you one example reported in Majah. Majah reported from Prophet Muhammad sallallahu alaihi wasallam that there should be neither harming nor reciprocating harm. And I also would like to mention that.
So sorry to interrupt. Really amazing, lots of information. If you would be able to wrap up in about a minute or so, I'd really appreciate it.
Definitely. It's so rich. Thank you for reminding me that. But I would like to mention and invite all of us to reflect on the name of Islam. Islam means not only submission. Islam also means peace. Peacemaking not only with people, but also peacemaking with ourselves. So this can also be used as a theological reflection to help people who suffer from eating disorders. Again, thank you so much for organizing this, and have a very good evening.
Thank you very much. So now we're just going to welcome Samiha Rahman to the virtual stage. She is a master's student in the Spiritual Care and Psychotherapy program at Wilfrid Laurier University. She identifies as a strong advocate for improving psychosocial health in marginalized communities and is interested in providing social justice healing for individuals with eating disorders. And we're very grateful for her coming here today, as she'll be speaking from personal experience.
Assalamualaikum. It's wonderful to be here.
So I guess I'll just, we'll have a couple minutes together. I'll just be asking you some questions that hopefully we can all learn a lot from. So first off, if you had to kind of highlight some of the most important factors that that contributed to your healing process or healing journey, what would they be? And what role did faith play in that, if any?
Yeah, so for sure, faith in Allah, that He was there and that this journey of mine had a purpose. That was one of the greatest factors in my recovery. And that's actually why I'm in the field of psychospiritual care right now, because I think it's so important and so needed. And another factor I think I would talk about is hope. Hope was very huge in my journey, and I imagine huge for others too. The way I kind of think about hope is I always imagined it as this spark that would be dim sometimes, but really bright other times. But it was this spark that would never let out. And that was a reminder I could and eventually would make it on the other side of this. And lastly, honestly, just getting lost in what I found was valuable and life-giving for me. I think that's a really important word, life-giving. And at the time for me, it was seeking companionship and finding purpose and meaning in that.
Thank you so much for that. I really appreciate your kind of holding on to hope and recognizing that even though it may not always have been bright, it was always there. So I think that's so important. And then also just speaking to the role community played in that. What did you find was helpful or unhelpful to hear from others? I'm sure you may have heard some comments, or if people were trying to help, but what they were saying was ended up being harmful. In that process, like, what did you find helpful? What wasn't helpful?
So what I had found, it was hard when my folks weren't as understanding or knowledgeable of how really multifaceted the illness was and the role it took in my life. It was actually limiting my ability to think clearly, focus, be present as a daughter, as a student, as just a functioning person. So I had wished there was a more gentle or nourishing approach to the situation, but I very much understand why it was hard for them to comprehend, much less treat. And helpful, I honestly am so blessed to have had access to the resources that I did. I recognize I'm a person of color. You know, I wear the hijab. It can be hard to access some low barrier supports, but alhamdulillah, my family practitioner, she was actually Muslim. And when I spoke to her about it, she really guided me through this pathway of finding resources that were accessible to me nearby. And alhamdulillah, I was able to access adult day program at North York General. So just seeking like psychotherapeutical support, like clinical support, and not just relying on myself and saying, you know, like, I have Allah, He will get me through this. Alhamdulillah, I do have Allah, and He did get me through this. But we're also taught in our religion to tie the camel and use our resources that, you know, Allah has given us. So that for me, that was accessing these real support from professionals.
I appreciate your highlighting how having illness also affects your ability to think, right? And that's not always something people can appreciate. So I'm glad you had your family that was supportive, you had your GP. So this is why I guess conference like these are super important in educating the public and our clinicians. Then my last question for you is, you've obviously very quite bravely and publicly shared your story. And through that, you've been able to build like quite an online community to support and build awareness around Muslims with eating disorders. What do you hope to accomplish with the project, and why do you think it's important?
So I began the page Muslims with Eating Disorder. It's right now it's on Instagram, but I have hopes that I will get to it and start creating websites. Just school has been a lot, so I'm just trying to finish that. So I began the page when I graduated from my undergrad. So I had this real fresh motive to make an impact and work with the time that we all had, because it was also the beginning of the pandemic. This time, I think, also was really hard for folks experiencing eating disorders. So I wanted to create an intersectional stance and viewpoint of eating disorders, and how there wasn't just like this one size or culture or specific type of person who experiences it. I really wanted to give birth to this really real experience I had, and to make others who experience the same or experiencing something similar a sense of hope. I also felt we needed more voices from marginalized members and the BIPOC community in this space. So this page is titled Muslims with Eating Disorders, because I think just the fact that it's called that, being Muslim with a mental illness, period, whole stigma to it. But to title it that, yes, I am a practicing Muslim who is also experiencing this illness that's often viewed as a glamorized or vanity-filled mental illness, can come across as taking a bold step. But I think it was a step that took up space and takes up space today, and in a very important way. I've heard stories from all over the world of girls saying how the page has really gave them a sense of mutual connection based on the religion and how they're trying to get better through this connection. And that to me alone is beautiful, and it instills a sense of genuine, meaningful connection. I do have disclaimers on the page that this is purely just inspiring, connecting virtual community, and that it's in no way, shape, or form a space where you can seek actual help and to try to seek psychological help or real support, clinical support. So yeah, I love the work that it has been doing so far.
No, I think it's super inspiring, actually, and I guess shining light on the reality of what it is, because like I think people who don't experience it or don't have a close person who have experienced it really don't know, right? Like you said, it can be glamorized in some ways, stigmatized, as we've heard earlier. So thank you so much for that. And now our two, Dr. Smith and Dr. Isgandarova, are also spotlighted on the stage for the Q&A period. I'm going to go for about 5 minutes. So I see one question in the chat here, or in the Q&A box. Somebody's wondering, do the mortality rates for eating disorders count as suicide? I'm wondering if this would also raise the rates among women as a result. If anybody feels hooked to take that.
Yeah, I'm happy to speak to that. Suicide is one of the leading causes of mortality in this patient population. So those numbers are definitely included. The other really common things are kind of cardiac effects, so disorders of the heart, are unfortunately kind of neck and neck with completed suicide as leading sources of mortality for those who have eating disorders.
I would also like to respond to that, especially like stigma around suicide, because Dr. Smith, you also highlighted the importance to take into consideration that social factors play an important role, but at the same time, we need to ask advice. Like some people tend to suffer more from eating disorders. We need to take into consideration what literature tells us about the abuse factors, for example, and also societal pressure. So all needs to be highlighted too. So Quran and Hadith is not specifically clear in terms of if suicide is haram or not. But what we need to take into consideration is that Dr. Smith, you say that it is kind of harming yourself, right? So similarly, Hadith literature and Quran also says that eating disorders harms you. And there is one powerful Hadith in Bukhari and Muslim. The Prophet ﷺ saw a man walking continuously, and he inquired about this man, saying that why this man continuously walks, and the people responded to him that this man wants to go to Hajj by foot. And the Prophet ﷺ responded that Allah tell him that Allah is no need of his walking, so let him ride. So taking into consideration this, so probably we can address some of the kind of stigma associated to eating disorders as well, but at the same time encourage people how they can fast in a healthy way. But thank you so much, Dr. Smith, talking about that. But again, we need to consider the fact that there is stigma highly associated regarding suicide in our community that needs to be addressed.
Yeah, and I also should have said that part of talking about this should be acknowledging that asking for help and seeking help could be a way to decrease those serious consequences or the mortality of these illnesses.
Thank you. And then just to wrap us up, if you could briefly comment on the role, so taking an Islamic lens, so I know there's like a sunnah about how much we should be eating, and then there's also in the presentation, we spoke a little bit to these cultural factors of, for example, like arranged marriages and having a certain type of body leads to like greater prospects or desirability, and how that can contribute to developing eating disorders among the Muslim population. Is that something maybe some of you could speak to? I can also clarify the question if that's helpful. Yeah, so I guess just commenting on, again, taking a more like Muslim, not really Muslim lens, but looking at the Muslim population, for example. So I know that both Dr. Smith and Dr. Isgandarova spoke a little bit to risk factors of eating disorders being to have a certain type of body image, whether it's societally imposed on you or by parents. And a lot of times in some Muslim communities, this can be imposed on women because of this idea of having a certain body type that makes you more suitable for marriage or a better prospect, for example. And then I know there's also sunnahs about how much we should be eating or how we're supposed to be taking care of our bodies. And if it's something you could speak to in the context of eating disorders and like risk factors, I guess, is what I'm trying to get at.
I think this is really very important question. Let's start with kind of, again, when we had the historical narrative of eating disorders, we highlighted the fact that in those days, in medieval times, women who suffered, who fasted, they did it for spiritual purpose only. They didn't have a concern of ideal body image in those times. However, in our modern time, people who fast and also they concerned about if they suffer from eating disorder, they not only do it for a purpose of fasting or spirituality, they also do it because of the social pressure, peer pressure, and as you said, to achieve the ideal body image. So in schools, for example, we know that even before school age, how many girls they receive Barbie dolls as a gift, for example. So if you measure up the Barbie dolls, the body kind of ideal for them, ideal body image is 38, 18, and 33, or kind of, I don't exactly remember, that's exactly how they say. So from psychiatric perspective, probably Barbie meets the diagnosis of eating disorders, right? So again, Hollywood images of women and girls. So then we also need to take into consideration and how Hollywood movies are very popular in Muslim countries too. So again, one study pointed out that the ideal body image in United Arab Emirates, for example, is kind of thinness and also kind of religiosity. So unfortunately, there's a social and cultural pressure on women and girls to kind of meet the requirements of body image, ideal body image in those societies. So men needs to be educated the same way we educate men in terms of domestic abuse. They also needs to be educated.
Well, thank you. Dr. Smith?
The way I would think of that is I talked about eating disorders as illnesses where some people are vulnerable based on their biology and the way their brain is wired. And then I said there could be multiple kind of circumstances, events, factors that could influence what leads someone to change their eating. And so I think kind of the expertise around what those risk factors might be in your culture, of course, you understand much better than I could. But I would think of them not as simply kind of causes of eating disorders. I think it's not that simple, but they might be modifiable risk factors that, if changed or addressed, could reduce the risk for those who are already vulnerable.
Thank you very much for your wisdom, sharing your experiences. We really appreciate it, Dr. Smith, Dr. Isgandarova, and Samiha. Now we'll be moving on to the next session titled Mental Health 101, Addressing Psychiatric and Spiritual Misconceptions of Mental Illness.